I'm Kim Kuebler and the editor-in-chief of the Multiple Chronic Conditions Resource Center. We are thrilled today to introduce Dr. Eduardo Bruera. He has an extensive bio that I want to share with you. Dr. Bruera obtained his medical degree from the University of Rosario in Argentina. He trained in medical oncology, and in 1984, he relocated to the University of Alberta in Edmonton, Canada, where he directed the clinical and academic palliative care programs until 1999. In 1999, Dr. Bruera joined the University of Texas MD Anderson Cancer Center, where he currently holds the full-time McGraw Chair in the treatment of cancer and is the chair of the Department of Palliative Rehabilitation and Integrative Medicine. He was also the medical director of the Outpatient Supportive Care Center for 15 years until 2018. Dr. Bruera's main clinical interest is in the care of the physical and psychosocial distress of patients with advanced cancer and the support of their families. He has established and led for the first 5 years of operations the Edmonton Regional and Palliative Care Program. That is where I met Dr. Bruera. He later established and currently leads the Department of Palliative Rehab at the University of Texas MD Anderson Center. He has been interested in the development of palliative care programs internationally and helped in the establishment of numerous palliative care programs in Latin America, India, and different areas of Europe. He has held leadership roles with the World Health Organization, the Multinational Association of Supportive Care and Cancer, the International Association of Hospice and Palliative Care, and Cicely Saunders International. He has trained hundreds of physicians, nurses, and other healthcare professionals in the different aspects of the clinical delivery of palliative care. He established the first academic fellowship program in palliative care at the University of Alberta in Canada. Dr. Bruera has more than 1,300 peer-reviewed publications and has edited 40 books. He has given more than 900 major invited lectures and has received multiple federal research grants in the U.S. and Canada. He has been named a Fellow of the American College of Physicians, American Academy of Hospice and Palliative Medicine, the American Society of Clinical Oncology, and King's College in London. He has received honorary doctorate degrees from the University of Montreal and distinguished visitor of the Catholic University of Cordoba. In 2024, he became the Master of the American College of Physicians. I also want to point out that Dr. Bruera is on our editorial board for the Multiple Chronic Conditions Resource Center and was also a co-author of the recent Integration of Palliative Care in Multiple Chronic Conditions, an expert consensus statement with policy implications. Thank you, Dr. Bruera.
Thank you so much. I'm sorry that was such a long introduction, but it's a long time I've been around, so that's the problem.
I think that's amazing. And to me, you're like the president of palliative care. I'm just thrilled to be able to have this opportunity today. You have been instrumental in shaping the clinical concepts and practices within palliative medicine from its early introduction, as we just learned about. Although most of your work is in the oncology setting, how can the integration and implementation of palliative care be used in the primary care setting for those patients living with non-reversible symptomatic chronic conditions?
Thanks very much, Kim. That's one of our big challenges and perhaps one of our unmet needs at this point in healthcare in general. The big challenge is that there is a lot of unnecessary suffering that happens way before a patient is referred to a palliative medicine specialist. And that is where primary care has a tremendous role to support those patients and their loved ones. What medications help? What investigations help? How do we guide decision making? And what words do we use? What physical postures work in supporting the patient and family and helping them reduce their suffering are not completely part of the training and practice of primary care. So partially, the main reason for that is we have not been successful at the curriculum wars, and we have not gotten the attention of the deans of medicine, nursing, social sciences, and we have not been able to somehow embed a lot of our body of knowledge into what is being taught and practiced. So I guess the opportunity is to reach out to those who can make the decisions, like Andy Warhol said, within the next 15 minutes, not the ones who might make decisions in 20 years, but those who have the power now, and encourage them to include some of that body of knowledge into the way we teach and the way we practice on a day-time basis. Because a slide presentation telling people what should be done is absolutely useless if when they go and see me practice, they don't see me do those things. So I think it's, first of all, we might need to teach our leaders. We might need to teach the deans, the presidents of hospitals, the people who make decisions, and then we might need to teach our faculty how to do it themselves and then teach it. In clinical care, we're so good at answering the multiple choice question perfectly well, but that doesn't mean we're going to go and practice that way later on. And we need to embed this into the minds and behaviors of our clinicians. I think it's an opportunity. I think things are getting much better, but we still have so much to go. So it's a great opportunity for somebody who is in the junior years of their career. This is a great opportunity because there's a lot of change that still needs to happen.
Absolutely. Thank you. So your tremendous body of clinical research on symptom management has been used to improve the lives of many patients who are living with advanced cancer. So how can palliative symptom management be used in the non-reversible chronic conditions to reduce disease exacerbations in patients who are frequently hospitalized for poorly managed symptoms?
Yeah, that's a wonderful point. I think regrettably, the world of healthcare is biomedical. It is what we find in the blood work, in the x-rays, the diseases diagnosed, and their management. And even the architecture of our healthcare institutions is biomedically oriented. It's not person-centered. And whenever I see a so-called improvement in a facility, I cringe because I know it's going to be the wrong colors, the wrong images, the wrong access, the wrong facilities, and so on, because it's all aimed to the biomedical problem. And of course, the personhood suffering does not always fit that well with the elimination of the biomedical problem. Because in people with chronic progressive diseases, by definition, the biomedical management will not make the problem go away. And with that idea of acute management and discharge that prevails in acute care, we fail to the patients and families because that is not embedded in all aspects of the moment the patient arrives at the front desk, to the moment the patient is seen in the rooms, to the way we decide about procedures. So I think our main opportunity is to make sure that a personhood component is part of every single biomedical protocol. Acute pneumonia, fractures, and then, of course, readmission to the hospital, consideration of transfer to the ICU. What are the personhood aspects? What are the values of this patient with the personal history of these patients? If we weave that into the decision-making process and the communication, I think we are already changing dramatically what is an essentially 100% biomedical approach into a person plus the biomedical approach. It doesn't take that much to develop rapport with a suffering person. And it doesn't take that much to teach our colleagues how to do that. So I'm optimistic that we're going to start seeing a shift from the purely biomedical aspect of I admit you because you have this clinical problem and I'm going to manage this and then get you out, to one in which I consider you as a person and I see really if this is in your best personal interest, medicine has been so dominated by the biomedical that you cannot die with a low potassium, or you cannot die with a high calcium, or with any other blood work that is not appropriately corrected. So it requires a cultural change of us to say, as you're approaching the time in your life in which we cannot cure your illness, what are the priorities for your well-being, and how do we emphasize those and start paying less attention to your magnesium and to your x-ray?
Right. And what about like preemptively managing symptoms? For an example, in a patient with COPD, we know that they have, frequent exacerbations. Each time they have an exacerbation, they lose their pulmonary function, which increases their debility and more inpatient admissions. So if a patient, when you talk about patient-centered care, and I believe that self-management is part of that, educating the patient about, their symptoms and being able to preemptively manage those so it doesn't turn into an exacerbation.
I think we have an enormous opportunity that was one of the few silver linings brought to us by COVID. That is, the same as you and I are now meeting and having a conversation, although we're far away from each other, but we can see eye to eye and we can communicate. We can visit our patients at home when they have chronic illness and have video consults with them, video visits with them. We can not only educate, but deliver care to those patients and families. And we can also do remote monitoring of their changes. We can send them patient-reported outcomes to be measured, and we can even measure some vital signs in those patients that allow us to start breaking that barrier between the institution and home. And of course, prevention and self-care are mostly taking place at home. And home was a black hole for most of us before COVID, because there were very few people visiting the home, very few people knowing what to do at home. Now, this barrier is being blurred. So we can visit our patients and their families, understand how they're doing, and we can use all our expertise to bridge that type of self-care, that type of rehabilitation. In the case of the COPD patient, are they going for the walk? Are they doing their incentive spirometry? Are they doing their toilet and cleansing? If not, what are the barriers? How can I help you? How can I help you physically, emotionally? And so I am optimistic that this idea of visiting people where they are is important. Now, to be able to do that, you and I are now spending time doing this activity. When a clinician is doing this virtually, instead of doing it in a patient that shows up to the hospital or at the bedside, they're not spending less time. They're spending the same amount of time. And therefore, it is important that our budgeting, and it's important that our institutions and our reimbursement respects the fact that we're delivering that care, so that it becomes, in a sense, we might call it professionalized, that it is part of the activities that institutions can plan. I believe that this would be of great help to insurers, because by reducing these unnecessary severe decompensations and admissions, at the end, you are costing a little bit of money by those visits, but you're saving a huge amount of money. And of course, I always imagine an emergency room visit as a terrible time, because all of us who have been to an emergency room know that it's a terrible place to be spending 6 hours or 7 hours and then deciding to be admitted. So the quality of life improvement we provide by visiting someone at home and preventing some of those visits is really of great value. I think we have an enormous opportunity that was one of the few silver linings brought to us by COVID. That is, the same as you and I are now meeting and having a conversation, although we're far away from each other, but we can see eye to eye and we can communicate. We can visit our patients at home when they have chronic illness and have video consults with them, video visits with them, we can not only educate but deliver care to those patients and families. And we can also do remote monitoring of their changes. We can send them patient-reported outcomes to be measured, and we can even measure some vital signs in those patients that allow us to start breaking that barrier between the institution and home. And of course, prevention and self-care are mostly taking place at home. And home was a black hole for most of us before COVID, because there were very few people visiting the home, very few people knowing what to do at home. Now, this barrier is being blurred. So we can visit our patients and their families, understand how they're doing, and we can use all our expertise to bridge that type of self-care, that type of rehabilitation. In the case of the COPD patient, are they going for the walk? Are they doing their incentive spirometry? Are they doing their toilet and cleansing? If not, what are the barriers? How can I help you? How can I help you physically, emotionally? And so I am optimistic that this idea of visiting people where they are is important. Now, to be able to do that, you and I are now spending time doing this activity. When a clinician is doing this virtually, instead of doing it in a patient that shows up to the hospital or at the bedside, they're not spending less time. They're spending the same amount of time. And therefore, it is important that our budgeting, and it's important that our institutions and our reimbursement respects the fact that we're delivering that care, so that it becomes, in a sense, we might call it professionalized, that it is part of the activities that institutions can plan. I believe that this would be of great help to insurers, because by reducing these unnecessary severe decompensations and admissions, at the end, you are costing a little bit of money by those visits, but you're saving a huge amount of money. And of course, I always imagine an emergency room visit as a terrible time, because all of us who have been to an emergency room know that it is a terrible place to be spending 6 hours or 7 hours and then deciding to be admitted. So the quality of life improvement we provide by visiting someone at home and preventing some of those visits is really of great value.
Absolutely, absolutely. So in your tenure of practice, you have watched the pendulum swing on the use of opiate analgesics, as the increased uptake of their use has led to what has often been referred to as a serious public health problem. Ethically, the optimal management of pain and cancer in non-cancer patients should be appropriately treated. But how do clinicians effectively manage chronic pain in patients with a substance use disorder?
Yeah, that's a huge problem, Kim. That is, unfortunately, we went from the opioid use epidemic to the opioid not use epidemic or underuse epidemic. And now we're having a huge amount of patients who are not receiving the cancer treatment, the cancer pain treatment they need. And basically, to give you an idea, in 2011, by the time the patients arrived to our supportive care center at MD Anderson, they were receiving 80 milligrams of morphine a day, average, by different opioids, by their primary teams, by the oncologists, the internists, and so on. By 2016, that number had dropped to 38 milligrams a day. By 2022, that number had dropped to 7.5 milligrams. In a decade, we went from 80 milligrams a day to 7.5 milligrams a day. And 40% of the patients that are arriving to our clinic now are arriving with cancer-related pain on 0 milligrams of opioids. And so a lot of suffering is taking place due to an unintended consequence on the war on drugs. The unintended consequence was, and it continues to be, that patients are continuously singled by their physician when they complain of pain, by their pharmacists when they go to the community pharmacy, and their pharmacist sometimes even refuses to fill up a prescription. They are continuously bombarded with opiophobia, and therefore they're afraid of taking their painkiller because that might kill them, that might render them addicts, and so on. And the reality is, the pendulum has swung in a way that I thought I would never see to the 70s. We're back to the 70s when the majority of patients were getting PRN opiates only, we're getting minimal doses, and we're not getting the cancer pain treated. There's no doubt that there was a massive harm caused by Purdue Frederick and the Sacklers and everything else. We know the whole story by advertising erroneously that opiates were absolutely safe, that people were not going to get addicted. Of course, it was wrong. We had been telling that since the 80s. We had been publishing that these are drugs to be taken cautiously and respectfully, and that patients should be screened for that risk. Regrettably, money talks, and we didn't have any money. And so, therefore, the epidemic happened. But the pendular effect is not healthy. It's not helping the patients who really need painkillers. So, what do we need to do as clinicians? First, we need to try to understand why the pain syndrome is there. And in my books, when a patient with cancer comes to me, I need to understand what is causing that pain syndrome. Is it metastatic disease? Is it locally advanced disease? Or is it just low back pain that they had for the last 30 years? So understand the type of pain. Second, understand the risk for my patient. They're very simple tools. The CAGE tool is 4 questions. Do I have to cut down, annoyed, guilty, or eye opener? The SOAP tool also has a little bit more questions, 14 questions, but they're both wonderful screening tools that are self-completed by the patient, that take seconds to complete. And that provides me some idea of the risk. If I understand the pain mechanism, and I believe this patient requires opioids, whether they're positive or negative in that screening, I will start them on opioids. So why am I doing the screening? Because that will provide me some idea of the vigilance I need. A patient who is scoring negative for those high risk scales, that is about 80% of the patients, can be seen in 4 weeks and can be given the prescriptions, and we just follow them up. A patient who scores positive in those scales because they have a history of alcoholism, because they have a history of using drugs, because they have a history of having had difficulties before, also needs the opioid because I am convinced that they need cancer pain treatment, they need medications, but my vigilance needs to be much higher. I will see them more frequently, I will do random urinary drug tests, etc. When a patient is high risk or low risk, it doesn't matter, but they start to come to the clinic with what we might call non-medical opioid use behaviors. They used to be called aberrant. We think that's pejorative. Non-medical opioid use behaviors is a nicer term. And then they start losing their medication, or they start coming to the emergency room very frequently. They start calling all the time. They start buying drugs on the street. They get a positive UDS. That patient, if you are not a palliative care specialist, please refer them, because they are complex, and they're way more complex than what my one-to-one care of the patient today might be. Not everybody who scores positive in the CAGE or SOAP questionnaires will ever engage in non-medical opioid use. They have a higher risk, but many of them won't. And also, some of those who have no risk will engage in non-medical opioid use. So my advice would be be compassionate, be kind, do not take away from patients medications they need. But if they behave in a way that suggests to you non-medical opioid use, what is the percentage of patients who will do that at some time? About 20%. About 20% of them might engage in those behaviors. Refer them to a specialty team, because we have interdisciplinary ways of dealing with them and providing them care, but putting a good limits so that they don't harm themselves or harm others. And that way you will be very happy that your practice is managing pain in an optimal way.
Yeah, that's perfect. Palliative care is often associated with end of life or available to patients when they are enrolled in a Medicare hospice benefit. For patients with advanced chronic conditions such as heart failure or chronic obstructive pulmonary disease, who often live for many years following their diagnosis, when would you consider, at what point in their disease trajectory, should palliative symptom management be introduced into their medical management?
I think that's a wonderful point, Kim, because as you very well pointed out, we moved from the very beginning of our movement, that was in the 60s, and it was truly in the last days of life, to a little bit earlier, that was seeing patients in consultation when they were admitted in the hospital, in the acute care hospitals, and that was a little bit earlier. And then we moved into the outpatient area. And that's what we started doing in Canada, where you visited us. And we started doing that in the outpatient setting, and the patients were coming to us a little bit earlier in their trajectory of illness. What we have done is we have learned that suffering does not start close to the end of life. Suffering may start much, much earlier. We also asked clinicians and got some consensus, but we also asked patients about when should they be referred. And what we have learned is that referral to a supportive and palliative care team, we use the term supportive care because we were not getting referrals at MD Anderson. We were not getting referrals because of the name palliative. And the oncologists were afraid of sending us patients because they said, oh yeah, palliative means hospice, and then the family is going to be upset, and I don't want to upset the family, and so on. So we used supportive care for our outpatient center. It's the same thing. We're all palliative care specialists, but we use the term supportive care at the front door, and that massively increased the number of referrals because they felt safer sending the patients to us. But when we did the survey of the patients, we learned that they're not so much worried about the timing in terms of chronology. They are worried about the timing in terms of suffering. So, if a patient that you are seeing has CHF, but is feeling profound fatigue, profound episodes of dyspnea, depression, anxiety, anorexia, the beginning of cachexia, that's a good time to send them. You don't have to wait until their ejection fraction is at a certain level or until their prognosis is at a certain level. And you know, if the patient improves, because either you do LVAD or you improve and you compensate them, they might see me 3 or 4 times, and then they might not see me for 5 or 6 months. But, and the cardiologist will continue following up on them, or the internist, but the connection is made. And next time they come, they're not going to be afraid. They're going to have built a relationship. And so I believe that my rule of thumb for the listeners is do it suffering-based, much more than chronology-based, and then the intensity of the contact will be quite different depending on the patient needs. When the ESAS goes down, they stop showing up. And we have done 3 different studies where we have found patients who do not come for follow-up to our supportive care center are not the ones who are too ill to come, are the ones who are too well to come, because they don't want to waste their time and energy coming when they truly don't need it. And then when things get bad, they come back. So I think patients are able to titrate themselves into the intensity. And I would tell our colleagues, don't worry about sending them. You just need to be sure that the team that's receiving those patients has been given by the hospital executives the resources they need to deliver that care. Because regrettably, many times hospitals engage in a practice called pallilalia, that is talking, but not putting any money to support those structures. And then you have only one supportive care doctor, and they get burned out and they leave. So you need to have the institution where you practice as a cardiologist, as a respirologist, as an oncologist, needs to provide you access to interventional radiology, to laboratory, and to supportive care teams that can help you when your patient is having a very, very difficult time.
Absolutely. So last question. In your perspective, how effective is the integration of palliative symptom management in multiple chronic conditions? when considering the use of healthcare resources, which we just touched on a little bit, since this is the largest, fastest growing, and most costly U.S. patient population?
That's a wonderful point. And we dealt with the COVID pandemic by rapidly adapting to what the limitations were in our practice and by changing our practice to accommodate for this pandemic. We're now, we don't realize it because it's a slower pandemic. We're in the middle of the chronic disease and aging pandemic. It is right with us already. It's driven by the demographics, by the baby boomers, by the longer survival, but it's also driven by the enormous, unfortunately, drug and electronic health record cartels that are inducing enormous harm by the cost of their delivery. And therefore, we are in a pandemic right now. Now, one of the challenges we have is that in healthcare, there is a big trend to look at the value of healthcare as effects, the value meaning the benefit that the patient gets divided by the cost. But the cost component is a bad thing, because the cost component, if you don't account for it carefully, you get the wrong conclusions. So if you believe that Bruera controlled the patient's nausea, depression, anxiety, fatigue, but it cost the treatment, the visit from Bruera and the facility fees, you are not understanding that the financial impact of Bruera seeing that patient has nothing to do with that. Has to do with the unnecessary use of MRIs, of targeted therapies, of immunotherapies, of admissions, of ICU, and we have demonstrated in multiple studies that those benefits are there. So if you tie the benefit to the billing of the practitioner rather than where it should be tied, that is to the expenses that did not occur, you might make the wrong assumptions regarding what supportive and palliative care can offer to your institution. And at a moment of the pandemic, this is a moment when many of our institutions need to rethink, need to re-engineer their practices. They now have to say, we cannot continue practice as usual because, among other things, insurers are not always reimbursing for those services, especially when the person dies. The cost is becoming unbearable, and we have a way out. And the way out is to provide those patients access to supportive and palliative care, because it's demonstrated to reduce all those costly outcomes. Now, we need to encourage our finance departments to read the literature. In my experience, they don't read it. They go from one meeting to another and they have access to other type of literature. So please do not hesitate to educate your executives. Your executives do limited reading. They have a lot of assumptions that they make that are outdated. Bring them the data showing that access to supportive and palliative care might be the solution to their increasing problems, and then they might see that bringing you is a great investment. In our institution, it took us a long time, but we ended up convincing them, and that's why they don't see us anymore as a liability. They see us as a tremendous financial asset to the place.
Yes. Still a lot of work to go, Dr. Bruera. You've been in the field a long time, but there's still a lot of work.
Yes.
Is there anything that we haven't touched on that you think is important for our audience?
I think that's the question I always ask my patients before I end the visit. Is there anything we should be discussing that we have not discussed yet? So I think you've been a great palliative care doctor, Kim. I would say that I think you touched on the most difficult aspects of this feeling. My main message to those who are listening today is please, first of all, do not despair. Things are getting better and they will get even better. But if you're considering the possibility of getting more involved in supportive and palliative care, I would like to tell you that this is a highly rewarding field. Alleviating unnecessary suffering is highly rewarding. It gives you rapid gratification because the patient is able to go to the bathroom, get better pain, play dominoes, participate in a wedding, and plan their end of life. So, yes, there is going to be suffering universally, but you can alleviate an awful lot of that. And so, please do not despair. Please do not feel bad about getting involved in this field because you can have a long career and you can have a long and very successful career.
Yes. And Dr. Bruera, you have given the field tremendous data and clinical evidence to support patients and, throughout their disease. I thank you for that.
Thank you. Thank you so much, Kim. Thank you for having me here.
Absolutely.